sides. Pardon? Yeah, please come closer to the microphone. Okay. Pardon?
We are all here, third-year medical student here to attend this Telemedicine conference from Patan Academy of Health Science. My name is Nishant.
Thank you. Thank you.
Next, Rural Hospital, please.
Hello everyone, my name is Roshan Kumar Mahato. I am a manager in Department of Community Program. So I'm going to present about rural healthcare services of Rural Hospital, Department of Community Program. Thank you.
Okay, next we will go to the friends from Philippines. Ateneo de Manila University. Someone is there? Do we have the connection? Okay, maybe not. Then we will go for the Center for the Rural Healthcare Telemedicine. Again. Hello? Is it already?
So maybe
yeah.
Catherine?
Catherine,
Can you say hello?
Say hi, everyone.
Hello, hi. I'm Katrine. I will be presenting together with Narayan on rural healthcare in Nepal.
Okay, thank you. Welcome. Yes, yeah. Please mute your microphone. Maybe there is some noise from your side, but it's okay. And we will go the
next, Narayan Ital from Germany.
Narayan Ital
Hello,
from
good
Germany.
morning. Hello, good morning. As Catherine mentioned, I will be presenting with her. And I'm from Munich, Germany. I'm not from medical side, but from technology engineering side. I'm aerospace engineer from German Aerospace Center, but I'm also interested in global socio-economic development. And right now I'm also doing a master's degree in international affairs and diplomacy, so I want to combine my technology know-how and my international relation background to promote, let's say, socio-economic development to developing countries, and Nepal is one of the developing countries where I would like to contribute in the future. That's why I'm interested to attend this session.
Okay, thank you. Thank you for joining us such a far away from us. Okay. Okay, the next one we'll go to Philippines again for University of the Philippines. This is someone, yeah?
Hello, good morning to everyone. I'm Darwin Lorenzo, the Chief Engineer for the University of the Philippines, Manila. And unfortunately, Dr. Raymond Sarmiento is currently in Taiwan to attend a seminar and supposed to join from there. And right now, I'm still trying to contact him.
Okay. And also from NAMS, Beer Hospital. Is there someone from Beer Hospital?
Okay, the last one we will introduce the from Taiwan, Puli Christian Hospital, Dr. Hansen Chen. Say hello to everybody.
Hello, this is Dr. Hansen Chen from Puli Christian Hospital in central Taiwan, a rural area. I'm from Department of Family Medicine. Our hospital engage in personal health records system development and also rural health care and long-term care integration. Thank you.
Thank you, Dr. Chen. Yeah, I heard you just had some network problem. I'm glad you solved it. That's very happened in the rural healthcare session. Yeah.
Okay. So last year there was a declaration by WHO, this health for all. So if we say health for all, if rural people don't get access to the health, then that will not be accomplished by 2030. So that this universal health coverage, it has been a very focused topic. So actually that is the topic for today's discussion. So we would like to start our presentation. First presenter is from Kirtipur Hospital, Dr. Kiran Nakarmi, Professor Dr. Kiran Nakarmi. He has done masters in surgery and then done fellowship in hand surgery. He is the only hand surgeon in Nepal actually. And then he also specialized in microsurgery, reconstructive surgery, and now he is very much focused in caring the burn patients. So and especially the burn cases are in poverty and in rural remote areas. So he is going to present on these challenges on burn care in Nepal. Okay, Dr. Kiran?
Thank you, Dr. Uday. Actually, thank you for the nice introduction, but I want to correct you that there are a few more hand surgeons in Nepal at the moment, and we'll be starting hand fellowship within 2 months' time. So that's a good news for having more hand surgeons for the country. Today's my topic is challenges of burn care in Nepal. We started doing burn-related deformities in 2004. We used to take care of the burn deformed patients with the help of organizations like Research International. But later we found out that the number of those kind of deformed patients did not go down because we were not taking care of the acute burn patients in the proper way, and there were no government facilities which are dedicated for the burn care. So we decided to start a burn center at the Kirtipur hospital. So it is one of the most active services that is available in the Kirtipur hospital. You can see the hospital in the picture. So actually we are tied to an organization. It's an international INGO based in California known as Research International. It used to be known as Interplast before 2010. They have been associated with us since the mid-80s. Actually, they used to come for the trip and they used to teach the local surgeons, but later on they started doing a focused training for the plastic surgeons in the country. Actually, they helped some of us to get trained in plastic surgery, and after that we became more independent, and now we are at the stage of autonomy, and we also run the plastic surgery residency. So we have not only Kathmandu as our center, but we go to 5 or 6 different centers around the country, and each of these centers get surgical service every month. So we are doing more than 50 outreach surgical camps every year. So these are the types of cases we have been doing since long time. It's 14 years now. We still continue to do this kind of cases, but we are also starting to do the acute burn since 2013. So if you look at the data, the fire-related burns cause really a big economic loss that is equal to 10 million daily adjusted disability adjusted life years. So this is the regular scenario of Nepal. Actually, I took this picture when I was in a remote outreach center. Patients actually do not have good access to the not only surgery but also to the medical care in general. So that is given by different papers like surgical conditions that account to 11% of global daily disability adjusted life years, and 2 billion people lack access to basic surgical care at the moment. And this is even more extreme with the plastic surgery, because if you look at the number of plastic surgeons in the poor countries, it's very limited. And even in our country, plastic surgery residency training program started only since 2009. So hopefully we will get more plastic surgeons in the future. At the moment, most of the plastic surgeons are focused in Kathmandu, but we have been trying to go out in the countryside through different outreach centers. So now coming back to the acute burn, this is the WHO data. You can see that most of the burns happen in the low and middle income countries, and that is there are many reasons for that. And it kills quite a significant number of people, and most of them are in the Southeast Asia. So women are also involved. Actually, most of our patients are women and children. If you look at the data from our hospital, women and children constitute almost 75% of the burn victims. If you look at the causes of death in women, you can see that burn is a major killer. It's even more than tuberculosis and HIV/AIDS. So same thing happens with the young girls, school-going girls from Southeast Asia. Burn causes more death than TB, HIV, and malaria combined. So it's same in India. Actually, this data maybe is a little bit underestimated, because some of our friends in India said that the number of burn victims in India could be as much as 3 million per year, and a lot of people die. Same thing with Bangladesh data, and a lot of people die, and a lot of children are involved. And same thing in Pakistan. So it's the same story not only in Asia but also in Africa, in the underdeveloped countries. So it can be taken as a forgotten global health crisis. It is there, but we have not been paying enough attention to burn care. Burn is not only a health issue, but it can be also taken as human rights issue, social issue, and economic issue, because it causes a lot of economic loss. You can see that it's almost 80 billion per year because of the disability and death. And I mentioned earlier that there are many reasons why acute burn happens most of the time in the developing countries. One of them is because we depend on the open fire for cooking and warming the houses, even lighting the house. Actually, WHO mentioned that more than 50% of the global population at present are using open fire for cooking. So now let's go to the challenges of acute burn care from my perspective. As I mentioned earlier, burn has a very high incidence. There are a lot of people who get burnt, but it's getting very low priority. There is no resource allocation from the government side. The private hospitals, they don't want to take care of the burns because most of the victims are the poor people, and it's a very costly service because burn care involves a lot of dressing, a lot of surgeries, a lot of rehabilitation, and you need a lot of people, a lot of professionals involved in the care of burn. For example, you need surgeons, you need anesthesiologists, you need therapists, you need psychologists, you need nutritionists, you need a lot of people to take care of the same patient, which is a bit different from other conditions. Talking about Nepal, this is like data from the government, which is I think it's gross underestimation. It says that 52,000 people die of burn. I mean, they get burned every year, and 2,100 people die every year. So that comes to about 186 burn incidents every 100,000 population. So if you look at the data from our hospital, which started in 2013, and at the end of 2014 we had the data, we had a total of 90 admissions, and you can see how it's exponentially increasing. I'm not saying that the incidence of burn is increasing, but the number of people who have been hearing about our hospital, they have been coming to our hospital in an increasing number. And if you look at the data from January 2018, in a single month we had 122 burn admissions in a single month. That's like an epidemic. And if you look at the number of survival, actually we had a publication from Pokhara in 1986 that nobody over 40% of TBSA burns survived in Nepal at that time. And when we started our hospital in 2013, our data was same, and we were very surprised. But later we realized that we have not done anything in the field of acute burn for so long. That's why we cannot expect any improvement. But in 2015 it was almost same. But 2016 and 17 we saw some improvement in terms of the survival. But again in 2018 it's too early to report it. But if you look at just for the month of January, the survival percentage is also not so good, because I think it is because of the burden of the work with the limited number of manpower and resources. So we have been getting patients from many districts of the country, and in 2015 there were patients from 35 out of 75 districts. In 2015, it was 54. It was gradually increasing. Now it's I don't have the data at present, but it's over 60 now. So other challenge for the burn care in Nepal is poor outcome. When the outcome is poor, a lot of people don't want to take care of those conditions, and there are reasons why the outcome is poor. If you look at the burn mortality in high-income countries, it is less than 1 per 100,000 population, and in lower and middle-income countries, it is much higher. So this is the government data for burn mortality. It is about 2,100 deaths every year due to burn. So if you compare the same thing for US and Nepal, US has got about 10 times more population, and they have about the same burn incidence. It's not much. 8 times more increase in incidences can be explained by the number of population they have. But if you look at the deaths every year, they have only 1.5 times higher death rate compared to Nepal for the 10 times more population and 8 times more incidence. So that also explains that we are dying unnecessarily of acute burn in Nepal and other middle income countries. And this is the same slide I showed you earlier. And if you look at the bottom line of this slide, you can see that mortality percentage of the admitted burn patients initially was 22%, and in 2017 it decreased to 19.6%. I don't think it's statistically significant, but there is a gradual decrease in death. But if you look at January 2018, which is, I think it's too early to conclude, it's again back to 21%. Another challenge is limited burn care facility. Actually, it's a very sad thing that Nepal does not have any government-run burn hospital. They have few burn care units in different hospitals. For example, they have a burn unit in the University Hospital, which has got 5 burn beds, and there is a children's hospital which has got about 22 burn beds. And there is oldest burn hospital in the country. Initially, it used to have 9 burn beds, but now they have increased recently. So, if you look at the number of people, population and number of burn incidents, the service is grossly inadequate. And in our center, we have 25 acute burn beds. That's a general ward, and we have 8 ICU beds. And we can also admit in other wards. So we have been admitting the burn in other general ward because we do not have enough burn beds. That's how we took care of 122 burn victims in a month during last winter. So as I mentioned earlier, there is not a single dedicated government center. There is a lack of training for the health professionals and in the periphery and also in the center, and there is no public awareness, and that results to lack of safety measures that makes the public vulnerable for the acute burn. So 3 E's is E indicates, 1 E indicates education of the people and health professionals about safety measures and first aid and how to take care of the burns in the first and before referring. The second E is the engineering. That is for the proper engineering. For example, when we are making roads, installing the electric lines, or wiring, electric wiring of the house, and the engineering in the kitchen. Those things can also play a role in preventing the burns. And the last E is the enforcement of the law. If you enforce those safety measures into law, then the incidence can be decreased. And the burn care, I already mentioned, I don't need to repeat it. It's an expensive care, and it involves the poor people. So that's a paradox. So most of the people cannot afford the burn care, and there is no government support. Nepalese government has been supporting many other conditions. For example, they have been doing free dialysis for the chronic renal failure patient. They have been doing the free renal transplant. They have been providing some money for the cancer patients. stroke patients. They have been doing a lot of good things, but we have not been able to draw their attention to help the burn victims. And most of the people are poor and the service is expensive. That means it's a very sad situation. And there is no insurance. Because burn care is a very expensive thing, a lot of the insurance companies, they won't be interested in insuring the burn care. And the government insurance also is nominal, and I don't think it can cover the burn care. So one of the challenges we have been facing is the delay of the patient coming to our hospital, because Nepal is a geographically challenged country. Most of the area is
Kiran, 2 minutes left.
Okay, I'll try to finish. I'm almost done. So if you look at the average delay in presentation, it's 8.6 in 2014, and in 2018 the number has gone down, because the people have now known that they get treatment at our hospital. It's very important, because resuscitation should be completed within 24 hours for the burn patient, and that determines the outcome of the patient. So that's really important for the people in the periphery to know that they have to do the resuscitation before sending the patient. Most of the patients, they come here in the ambulance, which doesn't have any paramedic and any facility for the resuscitation. So they come, they present at our hospital without any resuscitation, and many of patients have died of acute renal failure when they present to us. And the other thing is lack of first aid knowledge, not only among the people but also among the health professionals. If you look at the data from our hospital, you see that in 2014 nobody came with pulling of the wound, which is very important in decreasing the depth of the burn injury. In 2017 is only 3. So we really have to do awareness to change this scenario. And we don't have many hospitals which have critical care for the burn patients. Our burn ICU has got 8 beds, and we can ventilate at least 4 patients anytime if needed. It's not the state-of-art ICU, but at least we can save some of the inhalation burn victims. And other big challenge is the lack of wound coverage. We started the skin bank in 2014, but the donation has been very minimal. When we excise big burns, if we do not cover them immediately, then there is a chance of infection and patient can die of that. So immediate coverage is very important, and for that we need the allograft. And infection is very important, because we do not have an isolation facility. Ours is a limited space and manpower, so we cannot isolate all the patients, but we have been trying to isolate the multi-drug and extended drug resistant patients. And we have also been doing a lot of hand hygiene and rational use of antibiotics. And in most of the hospitals in Nepal, burn ICU is not there, dedicated operating rooms are not there, they don't get enough sessions to operate the burn patients who needs almost daily dressing. There are no burn wards, there are only few beds allocated for the burn patient, there are no proper dressing rooms. So these are the challenges, and we have been working with lots of different organizations to change the scenario. And attracting new generation has also been a very difficult thing for Nepal, because there is no training opportunity. There was no training opportunity until recently. Job placement is also a problem. Job security and the gadgets are very expensive. And referral system with proper first aid and primary care also changes the scenario. If the new generation can see the improved outcome, then they will be interested in taking care of the burn. Otherwise, it's really depressing to take care of the burn patient which doesn't have good results. So in conclusion, burn is a big problem globally and also in Nepal. Public awareness on safety measures and first aid has to be done, and government should probably focus they should work closely with private sector in the field of prevention, proper treatment and rehabilitation. Thank you.
Okay, thank you very much. Let's give him a big applause. Due to time constraint, we may have one question. Oppo, before the question, we just make an housekeeping announcement. Please remember mute your microphone after you talk, so we can have a clear sound environment. So, any question from the floor or from remote sites? Maybe not. Okay, then we go to the next one.
Okay, thank you.
Okay. Thank you, Dr. Kiran. So burn, it was a very dreadful condition, and it is really a challenge. I can see Professor Dr. Vishnu from NAMS. Can you, sir, please introduce yourself and say hello to everyone?
Hello. Good morning. I am Professor Vishnu, Professor of Medical Oncology and Program Director for the Medical Oncology Council in the NAMS. And I am involved in the telemedicine section of NAMS here.
Okay, thank you. Next presenter is Mr. Roshan Kumar Mahato. He is from Dhulikhel Hospital. He is a doctorate fellow of public health. He is doing doctorate in Khon Kaen University, Khon Kaen, Thailand, and he has done masters in public health in the same university. He has done bachelor in public health from Purvanchal University. He has many interest in, especially in community medicine outreach programs. He has done many research in tuberculosis in community. He is going to present on opportunity and challenge of rural healthcare services provided by Department of Community Program, Dhulikhel Hospital. Okay, Mr. Roshan, please.
Thank you so much for the nice introduction. Good morning everyone from Nepal. So you already got my introduction. My name is Roshan Kumar Mahato. I am working in Dhulikhel Hospital since 2003. I am working in the Department of Community Program. So today I am going to present about the... Is it okay? Is it clear?
No, just your desktop. But you please share your... I think you need to share your desktop. Is PowerPoint presentation. Right now, we only see your... Okay, here we are. Thank you.
Okay, so today I am going to present about opportunities and challenges of the rural healthcare services provided by Department of Community Programs, so Dhulikhel Hospital. So this is the place where we are now at the moment, and this is the area. In 1996 we started in this area, and now this is the first when we start the construction of the hospital. So this is the first phase when we start the construction of Dhulikhel Hospital, and we inaugurated this hospital with the presence of late King Brendra Birvikram Sahadev in 1996, and he is the Ramkantha Makaju Shrestha. He is now the president of the Kathmandu University, and he is also the director of the Dhulikhel Hospital. So actually he is the founder of Dhulikhel Hospital. So these are some pictures when we start Dhulikhel Hospital, and working with only the 3 doctors and the 3 rooms. And at the moment we are 425 bedded. So these are some teaching learning activities we started in 1997. So I am also the product of Dhulikhel Hospital. It's the Dhulikhel Medical Institute, and I was a student of the laboratory technician. The first I introduced in Dhulikhel Hospital, and after that I worked in Dhulikhel Hospital, and in 1997 we started the community program as well. So these are some snaps of how we treated on that time. So what is the motto of Dhulikhel Hospital Department of Community Programs? So this is a quality health service delivery. The second one is the rational community-based manner, and innovative public health interventions, and effective partnership programs, and the proper monitoring and evaluation, and the quality assurance for all those services what we are delivering. So now this is Dhulikhel Hospital. So we are the not-for-profit community model, the first kind of the community in the country. So this is like the first community hospital in Nepal, and I already told you we established in 1996, and this is a not-for-profit, not governmental community hospital. This is service provided for the Kavli, Sindhupalchok, Golkha, Sinduli, Ramechhap and Bhaktapur, so mainly of this area, but at the moment we have a patient from all over the Nepal. So it is a general hospital committed for the quality service, and it's a university hospital at the moment. So since 2002 it's like a university hospital, So, and now I'm going to introduce about the Department of Community Programs. So you have seen the pictures in the four corners at the moment. So you can see how difficult is the community of the Nepal. So you can see how we are making our road by ourselves to go to the community. Even for the ambulance, we didn't have any way to go. And for the medical doctors, when we are going to the camp, we have to use the ropeway or the rafting to reach our community. So this is a really outreach center. So, and then we started Department of Community Program in 1997. So the vision statement is like the Center for the Excellence for the Innovative and the Holistic Approach to the Community-Based Healthcare and the Community Development in Developing Countries. And the second one is the World-Class Center for the Study and the Research on the Community-Based Healthcare and the Community Development in Developing Countries. So this is the vision statement. So our core values, how we started and what is our core values is mostly the committed, dedicated, innovative, collaborative, and the service-oriented, of course, the aiming the excellence, team spirit, and daring. So this you can see already in the pictures. So how we access to the community, and of course the passionate. If we are not passionate, since 20 years we couldn't run these services to the rural part of the Nepal. So this is some clients. So we have like a staff, we have 126 staff in the outreach centers at the moment, and they are working for 24/7. We have like all type of staff, like the 14 outreach centers. We have medical doctors. They are working for the 24/7, and we have altogether 21 outreach centers of Rural Hospital, and we serve nearly 70,000 people in an year. So we serve 70,000 people in a year for the whole outreach centers. The programs we have like the health service program, public health program, community development, academic service, or of course the global health program, and health informatics programs, and the local incentive for the Rural community. This is the map of Nepal, and you can see like we are serving nearly the 9 districts from the outreach centers. So this is the whole scenario of the way we are serving. So the division of the department, how we are working. So we have like the health service section. We have a public health programs, community development, academic programs, global health informatics, and local incentives. Yeah. So in the health service, we have like the outreach centers, and the partnership program is outreach center is all run by Rural Hospital itself. Partnership is like we have 4 to 6 hospitals which can run by the partnership. That means we managing for the management part and the other parts, so we can look over them. So we are running the People Hospital, Tamakoshi Hospital, so some sort of the programs, and the health camps, of course, in the different part of the in our outreach center. Always we have specialized camps, and then in the other part of the centers, like last time we did it in the Ilam and in the Kalikot. So it's like all those health camps and other programs. It means other school health programs and other programs. So this is some snaps of the outreach centers where we are doing like the round-the-clock services to the community. We have a doctor visit, like the specialized visit from Rural Hospital to those centers. In the outreach center, we have a facility for the ambulance. We have a facility for the laboratory. At the moment, we added the facility of the X-ray, ECG, ultrasound. So you can say that all those basic facilities we already have in our outreach centers. And if they need any specialized services, we provided it from Rural Hospital. So these are some snaps of the camps. So we have also organized the camp with the help of the Korean doctors. Like he's Dr. Kim. I think most of the people you know him. He is a cardiovascular surgeon from Korea, from the ASNU, and then he also came here to Rural Hospital, and in collaboration with him, we conducted lots of camps, and also with the different countries, people from the different countries, we conducted lots of camps. So this is some snaps of the camps. So this is a trend of the patient flow of the outreach center. So in 2000, I didn't present it the whole. I just want to show about how we started and now what is the scenario. So in 2010 and 11, we had only 10 outreach centers, and the patient was 22,000. And at the moment, after 6 or 7 years, now we have a 21 outreach center, and patient rate is nearly more than double. So it's 52,586 at the moment. So it's increasing day by day. So, and the lots of people is coming there, and they are getting the facilities of Tulip Hill Hospital outreach centers. So this is some number of specialized camp, how we organize. So most of the places we organize the dental camps, and then the other gynecological camps, sometimes the surgical camps. So our surgical team, they are going to the outreach centers. We collected first the case, and then they operate there, and they came back. So this is a regular camps is doing in the outreach centers. So, and then for the holistic approach, we only not taking care of only the curative services, but also the public health programs. So like in the public health programs, we have women health programs, children health programs, and school health programs. So I just going to just elaborate about the women's health programs. So in the women's health programs, we have like 954 women in our microfinance group. This is the we are providing a small amount of money for the women empowerment, and then they start buying some animal husbandry or something, and side by side we are providing the skill-based training as well as the health educations for them. So this is called the women's health program. For the child health and school health program, so we have 31 schools. We are providing the child health and school health programs. So we have like student clubs and teachers clubs. So from that student and teachers clubs, we are providing like all those emerging and re-emerging diseases about the health education, awareness, first aid training for the school children. So these are some public health programs. Besides this, we have also like the community development programs. So like the improved cooking stoves. So you have seen the 87% nearly the people of the Nepal, they are using the firewood for the cooking the food. So and then we thought that the cooking food, the burning fuels is more effective to them for the making the COPD and something. So we just introduced the improved cooking stoves. So at the moment, more than 1,000 improved cooking stoves we have already planted in their houses, and it's going well. For the post-earthquake, you have already introduced about how the situation of the earthquake in Nepal. So we are at the prime center of the earthquake. So this is near the Sindhupalchok, Ramechhap, and Dolakha, and this is in Kavri. So and on that time we have actually we have served for the 6,000 people for the medical treatment, and after that we had a 3 motto actually. So one is the first the rehabilitation, and then the reconstruction, and then the rescue. The rescue on that time we did it, and the rehabilitation on that time we sent all those people on their houses with some help. And at the moment for the rehabilitation part, we are doing some constructions like some school constructions, some community houses constructions with the help of the lots of people from the outside the country and inside the country. And the microfinance I already introduced. And this is the SURE project, is the Survival for Revival project. So we did it in one of our outreach centers. This is agriculture project. So we train the people. First we enroll the people in the microfinance program, and then we train them. So how they can use their money in the good way to make the to improve their lifestyle, and then we train them with the agriculture things, and then they grow the things and they pay back their loan amount. So this is about the SURE project. And even though we constructed one of the bridge, you can see in your right side, it's the bridge we constructed from Tulip Hill Hospital, because there is no access to the people from another part of the hill to come to get the services from Tulip Hill Hospital outreach center there. So then we constructed the bridge as well. So some academic program. Now we are going to introduce a Master's Public Health program in Tulip Hill Hospital, in the Kathmandu University Hospital, with the epidemiology, and global health is already running from the nine countries. So, and this is the global health, some global health. So they came here to for the training for at least 30 days to 3 months, and then they can get the training in Tulip Hill Hospital as well as the outreach center, and they are going to introduce about the clinical services as well as public health program and community development program, how we are doing the thing. And this is the international participants. For the health informatics, so now we just started with the health informatics. So and then we are going to take the data of the family health program, is the the data of all women who are there. So we are going to register all, taking their all health, and then we are registering this one, and we are also going to record for all those things of the women's health, school health, and the livelihood database. So we are just going to introduce this program. So this is quite new for us. For research, at the moment, from Department of Community Program, we are doing the worksite interventions, National Non-Communicable Disease and the Injury Commission, the infectious disease, National Heart, Lungs and Blood Institutional Foundation grant, the World Diabetes Foundation grant. So these are some research we are conducting from our department. For the local incentives, we are collaboration with the Dhulikhel municipality on the 3 areas like the water sanitation and waste management, food handling and the hygiene, road traffic accidents. So these are some areas we are working with the local incentives. Some international collaboration we have from USA, of course, Europe, Thailand, Korea, China. So almost 15 universities in the close contact. So this is quite helpful for us to get our strength and then know about what are their feedbacks, and with their feedbacks we started to improve.
Mr. Roshan, 2 minutes left.
Okay. So, and now I just came to the point. It's the major opportunity and challenges. So of course our opportunity is the team clarity, interdepartment and interinstitutional collaboration, international collaborations, the proactive approach of the seeking opportunities, and to datum you can say the first deserve then desire. So this is the main point how we are working, and the creating opportunities rather than the waiting for them. So this is something what we are doing, and the challenges of course is like collaboration with the government is the big challenge at the moment, but we are doing in a very good way. At the moment we are running a lots of the government program in Dhulikhel Hospital as well as outreach centers. So institutional policy and the system, so we are going to strengthen our institutional policy and the system. So administration, finance, of course, we are running a lots of program, but the finance we didn't have all much, because from the rural health we are not getting a lots of money to sustain it. So that is the main challenges. The procurement, maintenance, construction, of course there is a lots of rules and how we have to manage. Media and communication, of course we are trying to make it better. So the streamline of the international collaboration, physical facility, so involving other departments as well. So for the surgical camps and other things. So where it was not reached, we are going to reach. So that is the main thing. The last point, the people who get on this world are the people who get up, look for the circumstances they want, and if they can't find them, make them. Thank you very much. This much is my slide.
Thank you very much. This was an excellent talk. Okay, yeah, we are open for one question, if time allowed. Anybody question from the floor or from the remote? Yeah, if you have a question, please raise your hand. We will. Okay. Talking about I have a question. You have any, because you talking about your aim for the holistic care. Is there any plan in Nepal? Is there any related to the hospice care? You know, sometimes people in the end of life, you have some. Do you have some also do some this kind of care or hospice end of life caring?
Sorry, I couldn't get you.
I'll answer him. I think. Yeah, there are holistic approaches, hospitals as well, like hospice, and but in community, like this type of hospital is very very difficult.
Thank you. Okay, thank you very much. And then now we would like to go to the next speaker.
Yes. Now next speakers are from Germany. They are going to present on innovation on rural health care. One presenter is Catherine Augustine. Miss Catherine Augustine, she is from Germany, and she is doing masters in global health with disaster and adaptation. She also has done PhD in neuroscience and pharmacology. She is very much interested in global health, and similarly Narayan Dhital, he is going to also present combinedly. He is presently working in United Nations Institute for Training and Research, Geneva, Switzerland. He is a certified air navigation service provider. So Narayan Dhital and Catherine Augustine, please. one of you first to start, and then maybe Narayan.
Thank you very much. Yes, thank you very much for the introduction and for the opportunity to present here. Narayan and I will be presenting together, and I will give a quick outline of the challenges that exist in rural healthcare and how telemedicine can help there. And Narayan will then talk more in detail on the technological challenges and innovation. So we are all here to talk about rural healthcare, obviously. So we are all aware of the challenges that exist in rural healthcare to address the Sustainable Development Goals. And that is a global problem. And in Nepal, in fact, there have been huge advances in the last 25 years in terms of maternal health care as the classic outcome of healthcare. As well as the amount of deliveries that are actually being assisted by skilled health workers, and therefore complications that could arise during birth that couldn't be prevented have risen quite a lot. And if you think about the Sustainable Development Goal targets that exist by 2030, on the current trajectory that Nepal is on, is very likely that. However, and this is where the rural healthcare issue comes in, there is a big discrepancy between healthcare that can be provided in urban areas and healthcare that can be provided in rural areas, as you can see specifically in terms of deliveries that are assisted by skilled health workers. I'm sorry, can you still hear me? And obviously there is a greater need to include hard-to-reach populations more proactively. And as we just heard, there are lots and lots of efforts to do this, and there have been a number of improvements in terms of patient recruitment. But the rural and urban healthcare divide still persists, and these are just a couple of further outcomes that have been measured in Nepal. And you can see that overall in rural areas, the outcome measures are substantially worse. And we have heard various reasons now from other speakers why this is the case. Interestingly, though, this is a particular issue when you think at the total fertility rates, which are higher in rural areas, and the fact that women bear children at a younger age, so their overall risk for complications, the number of pregnancies that they will have are all higher. And this is in itself, the fact that access to healthcare is so much better in urban areas is a big pull factor for greater urbanization and migration, which in turn then increases the burden on healthcare in urban areas and also puts rural areas much more at risk for better provision of healthcare. So what are the reasons why rural healthcare challenges exist in this form? And as you can all imagine, they are absolutely diverse. They range from difficulty in access, which is a particular issue in rural areas in Nepal. If you're looking at mountainous areas that may be prone to mudslides, to landslides, to poor infrastructure, less well-maintained roads, those are all problems in reaching health facilities in time. Often, a couple of research papers have found that there is a lack of trust in rural communities to health centers, and the reason for that might be, for instance, the phenomenon of ghost staffing. Now, even though health centers exist and our employed staff is not always available for their own very particular reasons, which may be easily also due to the difficulty in access. And finally, and potentially most importantly, social structures and community-based reasons very much contribute to people not being able to access healthcare, and this might just be as simple as having to provide for your family. If traveling to the nearest hospital to see specialists can take several hours or days, then this is time that land cannot be tended and that actually agricultural produce could be lost. And obviously, these challenges need to be addressed in order to avoid the aggravation and complication of diseases. And this is not just for urgent diseases, this is also for chronic conditions and the increasing burden of non-communicable diseases, which are also taking place, obviously, in rural areas and are completely underprovided. And also, addressing healthcare access can reduce the risk of food insecurity, and also, at the end of the day, the vulnerability to natural hazards during traveling times and so on. So this is very much a two-way issue. It's not just a matter of providing healthcare facilities for for people in rural areas, but also to ensure that we understand the reasons why people cannot access them. So how could telemedicine be a solution to this issue? I'm really sorry, I'm being a little bit confused right now. Can you still hear and see me? Hello? Okay, I'll just continue anyway, and I hope that you can still hear and see me now. I can't get back to my screen. Okay, sorry. As I was trying, as I hopefully could point out now, is that in order to move towards the Sustainable Development Goals, addressing healthcare issues addresses more than just Development Goal number 3, which is global health and well-being, that we can improve health outcomes with telemedicine, particularly by providing diagnostic and treatment support, especially in areas where there is little specialist care. And obviously this is less likely to address urgent care issues and surgery interventions, but definitely, hopefully, long-term and chronic diseases. By providing, linking rural health workers with specialists in the Kathmandu, for instance, or in bigger cities and other health centers. And this could relieve the burden that exists on patients by reducing the traveling times and encouraging health-seeking behavior in patients. If access to healthcare is easier, if talking to a local provider of healthcare is more likely, then this could, in the long term, make it much more likely that people are actually seeking healthcare. And also, importantly, this telemedicine has been shown to address the shortage of healthcare workers in rural areas. And with that, I mean by not necessarily having to recruit and retain specialist health workers in rural areas, because that is a major issue. Finding people who are willing to work in rural areas where there is less support on average, where there's less provision with medical material and with medications. So by having this connection to specialists, you do not need to have specialists necessarily there in place, and it is more likely that you can provide trainings and options for career development remotely for health workers to contribute to greater health worker satisfaction and better retention. And I will now pass over to Narayan, hopefully.
Do you hear me?
I can hear you.
Okay. I don't know about others. Oh, it's muted for others. Anyway, I need to save the slides.
Finished? Catherine?
Yes. Catherine, so finished the part. Now I have to continue the remaining presentation, and at the moment I want to share it. I hope it is principal to all the audience. So Catherine mentioned about the telemedicine and the use cases of technology for rural healthcare. And it is true that technology brings a lot of benefits, and technology provides healthcare services from maternal health to other epidemics. However, there are certain challenges that we need to consider while applying telemedicine in rural healthcare. And I have pointed out three main aspects here: the holistic aspect, user-centric, and measurable. That when we apply telemedicine, it needs to consider all aspects of rural healthcare. It's not just focused on one part of the country or just in one health center. Let's say it should be centralized and the database should be central, but it needs to be connected to all parts of the countries. Similarly, we should measure how this technology is impacting the overall health system. If we do not measure and control it, then we will not achieve the full benefits that are provided by modern technologies. And we also need to consider the user side, how they are equipped with different technologies like mobile phone, smartphones, mobile applications, and we need to do a survey to find out the situation in rural health, rural sectors, and according to that, we need to implement different telemedicine services. And this solution is a bottom-up approach. As I said, we need to go from ground level, so the local level. We need to understand the social aspects, economical aspect, the environmental aspect, and we also need to consider how knowledgeable the local community is. And we need to consider the national innovation level, which is how equipped and how aware they are about the challenges that they are facing in terms of health and how they can use the technology to their benefits. And from this understanding with local level and interaction with socio-cultural and economic aspects, we need to go from local level to higher level, and from that level to the innovation and technology level, which is carried out by this national innovation level, which I will discuss in the last slide, but it means the innovation and technology in national level. And this technology learning is to prepare for nationwide implementation of not just the telemedicine sector, but it applies in any kind of technology in the country. And I want to focus here on this technology leapfrog, which is basically when a developing country try to catch with the modern technology that is in the Western world, then there is always the issue of this technology leapfrog. For example, there is this 5G communication, which is a big thing for the future, and if a country like Nepal wants to implement this 5G communication, then we have to think a lot about this, whether we can do it or not. Similarly, there is a case of the CHRT satellite transponder, which was the CHRT satellite launched by the CHRT community, and Nepal was given a place to have a transponder in this satellite, but because of the lack of know-how, we were not able to utilize this satellite transponder. And I read one of the articles published in the newspaper recently, and it said that it could have been used for telemedicine. And the problem mentioned in the article was that people in medical sector, they are not aware how to use this satellite transponder to benefit the rural healthcare services. And this is because the problem of technology leapfrog is there. We want to catch to the modern technology that are existing in the Western world, but we do not know how to do that. And if we just implement those technology, then we are not able to use in let's say to exploit its full benefits. So the technology leapfrog is a very big challenge for a country like Nepal. And the effectiveness of this technology depends on the national innovation system and absorptive capacity. As I mentioned, if there is system, then the people and the workers that are working in health services or in technology services, they need to understand what this innovation system is. So there needs balance between technology transfer and technology learning and the absorptive capacity. It should be balanced to use the technology in appropriate way and to exploit its full benefits. And this is the innovation framework that I mentioned earlier, and this framework is currently planned for Nepal, and we are working together. For example, the Nepal Astronomical Society, UNOSA, and ICAO. We are planning to implement this communication, navigation, and surveillance system first in Kathmandu, and then to the all sectors in Nepal. So I have summarized this framework in three terms plan. The short term, which started this year, and we are working to form a working group in Nepal Astronomical Society, and this will be the basic for us. And then in the medium term, let's say in 3 years, we will have ground-based infrastructure deployed in different regions of Nepal. First, we will start from Kathmandu, and this infrastructure will collect the data. It is not only about the health data, but it also includes the climate data, the navigation data, and how the communication system is working in Kathmandu and in rural sectors of Nepal. And in the long term, it will evolve to CNS services, which is applicable to different end users. For example, health services, even for aircraft operation, road traffic, search and rescue missions, and health and emergency medical services operators. It could be used by drones and helicopters, especially in rural areas of Nepal, where the operation of drones and helicopters is very challenging because of the narrow valley and obstruction from the terrain. As I mentioned, the potential partners and the entities that I'm in collaborations are UNOSA, the ECHO, and WHO, and I'm also a member of Nepal Astronomical Society, and we are also trying to implement a coursework in engineering of it's IOE Pulsok, and we are trying to set up an institute where we can get students involved and do research in relation to health or even for technologies, for example, satellite technology, navigation technology, etc. And the long-term plan is to transfer this technology to the companies and to provide services in different sectors in Nepal. To summarize,
2 minutes left, Mr. Narayan.
Sustainable development must address the rural-urban divide. So we need to understand the local challenges in healthcare and rural settings, and we can implement telemedicine to overcome these challenges. However, as I mentioned, there are certain challenges even for technology implementation, and we need to carry out the bottom-up approach to understand the local infrastructure, social aspect, economic aspect, and cultural aspect in the local level. And it should be user-centric, and the technology should be measurable for its controlling. In sustainable implementation, it requires balance between technology transfer and technology learning in terms of absorptive capacity. And the long-term contribution is only possible with national capacity building and industrial development. Thank you very much.
Okay, thank you very much for both of you. Thank you, give a pause. And can we have a few questions for previous two speakers? You're welcome to raise your hand, and you can start to speak to raise your question. Yeah, welcome. Yeah. Question? No?
We'd like to request for NASO to unshare your presentation. Thank you.
Okay, thank you. Okay, and so, the final one?
Okay, next presenter is Patria Garcia. She is from Philippines. She is from Institute of Philippine Culture, Antonio de Manila University. She will be talking on information system e-health in achieving this universal health coverage. Ms. Patria, please.
Some technical issue we will solve soon. Please wait.
Ms. Patria is presenting from the hall itself. So all the presentations till now, they are very nice to achieve this universal health coverage by 2030. This we have to focus on burn care, as Professor Dr. Kiran has mentioned. It's a huge challenge in rural and remote area. And another was from Tolikel Hospital. This without community approach, without approaching to the remote areas, this universal health coverage cannot be achieved. Okay. And the third one was also very nice. That is why we also like this APAN, because here we have technical team, engineering team, and medical doctor team with public health experts. So that is why it's a combined team, and with our combined effort only we can achieve this universal health coverage by 2030. Let's hope by 2030 we will have health for all achieved.
There's some noise, so just remind remote side, please mute your microphone. We hear some noise. Only when you like to talk, please just most of the time mute your microphone.
Okay, this Patrick here. Yep.
Okay, hello. Yeah. Thank you to the technical staff. Okay, hello everyone. I hope it is a welcome change that the presenter for the last leg of the session is physically present. I would also like to say hello to the people on the remote. So, yeah. I am Patria, as mentioned earlier. I am from the Philippines. I work at a university, the Ateneo de Manila University. I specifically in the research department of the Institute of Philippine Culture. So at the last session, we will be talking about, I hope it's something lighter for everyone, about e-health or information systems and how and its role in the universal health coverage in the Philippines. Okay, so I'm going to go through this very quick because I know we're all aware of this. So first and foremost, the World Health Organization defines universal health coverage through, or that includes the whole spectrum of health services, from promotion, treatment, prevention, rehabilitation, what have you. And it also emphasizes on the reduction of financial burden through of the people when they are trying to access health services. But we have to be very vigilant in looking at the part that it's not just, or UHC is not just about health financing, but it also encompasses other facets of the health system, considering governance, health facilities, the actual facilities, equipment, our health workforce, health technologies, and what I am here to talk to you about today, information systems. So the Philippine national agencies have been working together towards the goal of reaching universal health coverage in the Philippines. For example, we have the Department of Health, of course, through their boosting of the financial health care via the Formula 1 Plus, otherwise known as the F1 Plus. As you can see, they have four strategic pillars, and then they have the Plus, performance, and accountability. In the fourth pillar, under governance, you have drive timely, evidence-informed, and data-driven decisions to mandate regular submission, automated, of clinical, administrative, and financial data. They also want to build capacity for health policy and for health systems research. Other national agencies involved with the further development of e-health in the Philippines would be, secondly, the Department of Science and Technology, Department of Science and Technology through the National Unified Health Research Agenda, or they call it NURA. One of them, NURA is actually the national roadmap, or it provides a national roadmap for the Philippines for its health, for all the health researches, one of which our project is a part of. So one of its main themes is responsive health systems to assist in health governance, health information systems, health financing, etc. And then, of course, we have the Philippine Health Insurance Corporation, or we call it PhilHealth in the Philippines. They have the primary care benefit package. This is the benefit package that enables eligible members to obtain primary preventive services, diagnostic examinations, etc. But at the minute, they're also trying to expand the member enrollment, and as well as they're also trying to expand the benefit inclusions and covering medications, which comprise the biggest out-of-pocket spending for the Filipinos. Okay, so now we go to the importance of e-health. So I think this is very basic for everyone here. So number one, importance of e-health is to improve the quality and the safety of the health system through empowering the health consumers, or basically the patients, or just about everyone, to better manage their health records. Because usually when we have our records paper-based, only the doctors are able to see that, or their nurses. You know, we don't really have that kind of information that we hold on to. And then secondly would be to ensure the availability of information at a single point of service. So once we arrive at a health facility, our records are available. Third would be it aids as a decision support and knowledge-based information. Thereby, it tries to reduce medical errors, although this is still a hot topic for the Philippines because, you know, we cannot really avoid biases when it comes to medical records. So yeah, we are working on that. And number four would be to ensure the availability of information for efficient and effective surveillance. So we are actually working towards this through data analytics. So we use all the data that we gather. Of course, these are all confidential. So we just use the aggregated data for surveillance and monitoring of diseases and management of health. So at the minute, the Philippines is working towards the Philippine Health Information Exchange. So as you can see, we have a lot of electronic medical record providers. So we have Cheats, we have WA, iClinicsys, and Shine OS Plus. Sorry, I forgot to include that. But the project that I'm currently in is actually one of the providers of electronic medical record, which is the eHatid LGU. I think I have some Filipino friends here. Hatid in Filipino means to deliver. Although we don't directly claim to be trying to deliver better health service, but I hope we are one of the stepping stones of the facilities that we cater to towards achieving that. Okay, so the Philippine Health Information Exchange is where all of the data of all these providers come, or these are pulled. All of our data are being pulled by. This is currently managed by the Department of Health and PhilHealth, or the Philippine Health Insurance Corporation. So that is how PhilHealth provides the payment for the health facilities that are PCB providers in the country. Okay, so now we go to the project that I am involved in. So again, it is called eHatid, and it comes into play. So number one, it's a medical record system that captures at the grassroots level. So these our tablet devices are actually deployed to rural health units in the Philippines. eHatid is also an accredited system, as you have seen previously. Third, it is a mobile-based application, although we are only exclusive to Android, but we're trying to move towards catering to iOS users as well, because a lot of the doctors in the Philippines actually use Apple products. And we also store and manage our data in the government cloud facility. So the Department of Information and Communications Technology provide for the storage of our servers, etc. The EHITID project is monitored by the Philippine Council for Health and Research Development, or PCHRD, and it is implemented by our institute, the Institute of Philippine Culture. So this is basically what you see on the screen is what our framework looks like. So, okay, so we have the government facility cloud, and then you have several RHUs pushing all of their data or submitting their data to the government cloud. But we have to note that these RHUs do not see each other's data, so they can only access their own, the ones that they have encoded into the tablet device. Okay, let's now go to how the tablet looks like. So these are the major systems that we have. This is the tablet or the mobile-based application. We have a separate one, which is a web-based. So the main mobile application features are, number one, of course, the electronic medical record, where we store all of the patient information. Number two would be the graphs and reports. So immediately, the municipal health officer could immediately see the data that they currently have on their system, but they can only access this online. Third would be the alerts for notifiable diseases. Some municipal health officers actually want to be notified, so they can put a threshold on a certain type of disease. For example, they want to be notified if dengue cases are slowly rising within, they can put a span of time like 24 hours or 10 hours, a couple of days, and then the system alerts them of that if ever that disease reaches that threshold. Fourth would be, fifth, would be the mayor-doctor communication, although this is something very similar to our messaging apps, just our messaging apps like a Viber or WhatsApp probably. And then lastly, we also have offline encoding. So I'll talk about the challenges in the rural health units of the Philippines later, but we have this feature as well. Next would be the expansion of the EHITID project. So we are, as I've mentioned, we are an electronic medical record, but during the second phase of our project, we're also working towards health and non-health systems of the local government units in the Philippines. So we are trying to create an interoperability platform for all of these, for the local government units that we are a partner of, and try to help them better manage their databases, their registries. There was one case with the pilot site that we are in. They have more than 10 databases and registries, I think. So their citizens would actually have to line up for a couple of times just to get either their medical certificate or their work permit. So yeah, that's one of the things that we're trying to address, and I hope it progresses as the months go by. You can also see here that their reporting to national agencies would just pass through the interoperability layer alone. So the LGU would actually be better cost efficient with having the interoperability layer, because they wouldn't have to manage several databases one by one. So they can just ask all of these databases and registries to be at one point or to be interoperable with the single layer, and then that will be the one to provide them with submissions, recordings, etc. Okay, so the last part of my talk would be the challenges in the implementation of e-health in the Philippines. So the Philippines has an archipelagic structure. So we consist of 7,107 islands, and we have over 100 million population. I heard that's like just 30% of Singapore. So Singapore is just 30% of the 100 million that we have. So I think the challenges that we have creates a domino effect. Because number one, limited internet connectivity throughout the whole Philippines. I mean, even in Manila, we have very fluctuating internet connection. But if you go to the provinces, the signal is can be very bad sometimes. I mean, not all, but some of the provinces, like the remote provinces, experience that. So of course, that translates to limited use of ICT infrastructure, which also then translates to no access to health records of the patients. So they experience the delayed access to real-time health information, and they have difficulty in accessing healthcare services, of course. Another challenge that I was not able to include here would have to be the drastic change from paper-based recording to automated. I mean, a lot of the municipal health officers tend to not be swayed by all these technological innovations, because it will require them to learn a new system, they would have to adapt a different system to their rural health unit. So I think that's one thing that we have to work on with them. Another would have to be by strengthening the capacity building. So we have to admit that not a lot of the Filipinos are very adept in using technologies such as this. So we try to combat that by making our system really user-friendly. So as if they're just using Facebook whenever they're encoding patients. So we hope we are achieving that. Another initial solution would have to be the free Wi-Fi nationwide by the Department of Information and Communications Technology. But yeah, making information systems more user-friendly. So yeah, I think that's everything I have to say to everyone. These are the sources that I have. So if you want further reading on any of the slides presented, then you can visit all these links. If you have any suggestions or ideas on how we can improve the landscape of the Philippines when it comes to rural health units towards universal healthcare, they would be very much welcome. Thank you.
Thank you, Ms. Patria, for your wonderful speech. So we have a few minutes to discussion. Any question for the previous speaker or the other four speakers? You are most welcome, remote side or locally. Yeah. So can we have a view for every site so we can know who is going to raise the hand? Next question. Any question from the Kathmandu Model Hospital? So Pato, yeah, Pato, please.
This is Pramod from Patan Academy of Health Science. I am a technical person, not a medical person, but I have a question regarding this experience. How do you coordinate in the hospitals? And there might be challenges also, or you might have a good experience to coordinate between the hospitals. There might be private hospitals, community hospitals, government hospitals. How did you coordinate between them? Thank you.
Yeah, how do you coordinate between hospitals for these data? Because he thinks it's difficult to coordinate among the hospitals.
Among the hospitals, yeah. Hi, sir. Thank you for the question. For the hospitals, actually we don't cater to the private hospitals. We mainly serve the rural health units in the Philippines, but we have another layer of the project which is called ihambing, or it's comparative analytics. So this is provided to the provincial and the regional offices who are interested in knowing getting the aggregated data of the rural health units under their catchment, and this basically makes it easier for them to compare data between the rural health units.
Satyas, please.
Yeah, thank you so much for the wonderful presentation. Is it a government-owned project?
Good.
The work, whatever you specified, is it a government-owned project?
Yes, yes.
No, the data what you collect, and you upload in the cloud, is the data is accessible by only by your people, or the government can access the data?
Storage of the data is in the cloud, yes, but the actual patients, like the details of the patients, can only be viewed by the municipal health officers, the rural health unit. But they have to have the informed consent of the patients whenever they have to upload it to PhilHealth or to DOH or the Department of Health.
You take a consent of the patient when
Yeah.
you're collecting the data?
Yes.
Okay, thank you.
Thank you.
Yes, this patient's rights issue is always here.
Yeah.
I can see our leader in this auditorium hall. Maybe Professor Shimizu would like to say something finally. Okay, thank you. We can conclude.
Yes, it's been a wonderful time. We have such a very interesting and a very valuable discussion, and we really hope that this kind of collaboration and experience sharing can carry on in the future. And thank you for all the participants, your great contribution, and all the audience. And particular, just remind you, and please fill up the survey, online survey sheets. We need that, and your valuable every opinion is highly appreciated. And so we thank you for your join us, and this session is going to conclude.
So is there anything that you would like to add from remote areas? Okay, Dr. Puja? There is no audio. Sorry. We can't hear you. It is mute still.
Hi everyone. I'm very excited to share a big news with all of you today. We've been working on telemedicine for quite some time. And there used to be questions like, how would you deliver medicine or the example? Because telemedicine is something that the specialist can consult over the telemedicine equipment. So we've been working with Dr. Navivwan, and he has finally, our medical drone is ready. And we'll be testing it quite soon, maybe next week. And I'm really excited and wanted to share this with you all. It's by the name of Medicopter. You can Google it if you want. Thank you.